I'm here with Dr. Endy Dominguez, a pulmonologist from Texas Tech Pediatrics. Dr. Dominguez, could you tell us a little bit about yourself?
Hi, Armin. How are you? It's nice to talk to you now in this new phase of you doing emergency department. So I think you're going to be great. So, but thank you for inviting me here to talk a little bit about asthma. So I'm a pediatric pulmonologist. I'm from the borderland. I trained myself in New York. I did a residency and a fellowship there, and I have been here in El Paso. Came back in 1 year ago, a little bit more than 1 year ago, and then being like assistant professor here at Texas Tech.
Awesome. Well, we're glad you came back to El Paso, and especially here in Texas Tech. Well, I personally heard your live lectures in the pre-COVID era. I know you're passionate about teaching so much that since your first year as faculty, you won the Dr. Peinado Excellence in Teaching Award.
Yeah, that's right. I don't know, I was very surprised, but yeah.
I wasn't. Okay, so let's get started with asthma.
Yeah, well, asthma, we have to remember that asthma is a chronic condition. It's I think probably the most common chronic condition in childhood. Is roughly around 8.4% of American kids will have asthma. And it's very common for you guys to see it in the emergency department. So you guys have to be ready and understand that it's a condition you need to be very aware and how to treat it.
Okay, and so patient comes in, with respiratory distress, signs of asthma, and I've seen that many physicians play like a hot potato game in the diagnosis of asthma, saying, I don't know if he has asthma, maybe he does, but I don't want to tell the parents. Can we diagnose asthma in the ED?
Well, I mean, that's an excellent point that you're talking right now. So yes, actually, asthma is something that sometimes, and for any reason, for a long time, it has been very, I don't know if it's like taboo word or what it is, but the people are afraid to make the diagnosis. For sure, you can make the diagnosis of asthma. That's one of the things that we have to point out. Remember, the hallmark of asthma is the airway hyperresponsiveness, patients that come with intermittent symptoms, which is very important to mention, of cough, wheezing, shortness of breath. And especially in preschool area, you will notice that these kids, they're always wheezing. They have a cold. This cold prolonged for a couple of weeks unless you give albuterol. So actually, you can give that diagnosis in the emergency department, of course. One of the other important things that we have to think about asthma is one of the other, I don't know how to say it, it's again taboo or myth, is that we cannot diagnose asthma if the kid has at least 5 years of age. That's not correct. And in fact, when you go to the tables of classification, there's 3 tables very important. When you see tables from 0 to 4 years of age, from 5 years of age to 11 years of age, and from 12 years of age up to until adulthood. And there's a little bit of a difference of criteria, but yes, you can make a diagnosis of asthma before 5 years of age. So it's important also to point it out.
Okay, and what tool would you use at that moment to make that diagnosis?
Well, the diagnosis of asthma is a clinical diagnosis. This is very important to point out. A lot of people, and probably that's the idea why people think that we cannot diagnose asthma until 5 years of age. We have to understand the American Thoracic Society recommend to start doing pulmonary function tests around 5 years of age. And only from there comes the idea that we need to wait until 5 years of age to make the decision or to make the diagnosis of asthma.
That's interesting.
However, by definition, we have to understand that mild persistent asthma will have a normal pulmonary function test between exacerbation. So a normal pulmonary function test will not rule out asthma. So yes, you can use, again, a spirometry. You can have some markers via the blood, like eosinophils, levels of Ig. But at the end of the day, asthma is a clinical diagnosis.
Okay, so patient comes in and I'm kind of suspicious of this asthma. Is there any questions or any scoring system that I could use to diagnose him?
So, well, regarding To make a diagnosis of asthma, again, it has to be is clinical, and it will depend in symptoms. It will depend of impairment of activity. Will depend on how often they use steroids or not to make the diagnosis, and then later the classification. But for example, one of the tools that you can use in the emergency department, or even when they're admitted, we have any doubt, patients that are less than 3 years of age, when they have these repetitive wheezing episodes, they come all the time. We cannot say if it's asthma or not. We have a tool that it calls Asthma Predictor Index. Now, this tool, it is not to use for patients to make the diagnosis of asthma, but to these patients, if they have a positive Asthma Predictor Index, increase the likelihood to be diagnosed with asthma by 5 years of age. And you have major remaining criteria for this for the Asthma Predictor Index that you can look, and it's very easy. Major criteria: if you have a family history of asthma, and it has to be the parents, it has to be man or that. That's positive. If you have a history of eczema, but diagnosed by a physician, that will be positive. Or if you have environmental allergies, again, has to be objective, meaning has to be via blood test, or has to be done by skin test allergy. If you have at least one, that's a positive Asthma Predictor Index. Now, you have the minor criteria will be, again, food allergies, but again, has to be documented. Number two, wheezing apart colds. The patient has been wheezing apart colds, that will be another. Or if you have eosinophilia more than 4% in your CBC, that's also positive. So if you have at least two of the minor, that will be a positive predictor index that you have an increased risk between 60 to 80% to be diagnosed with asthma by 5 years of age. So you have a small baby, a 3-year-old, 2-year-old, coming all the time with wheezing. Nobody has asthma. The dog last name is Floven. The mom last name is wheezing, and the patient always get better with albuterol. Please name the way it is. It is asthma, and that's good, because then when you do your disposition, let's say this patient doesn't go to the PICU or to the floor and goes to home, then you can send to the pediatrician or a pulmonary specialist with a diagnosis, and patient will have a better outcome at that point.
Oh, it's really good to know, and some things to ask and look for whenever you have the evaluation of the patient that's coming through the ED doors. So I know there's different types of asthma. Does that matter for us in the ED?
Well, that's very good question. There's definitely different types of asthma. You have viral-induced asthma. You have atopic asthma. But at the end of the day, you will manage at the emergency department the same asthma, the same. You have to start your short-acting beta-agonists, your corticosteroids, Ipotropium bromide. You will do the same management. There's this neutrophilic asthma that we're talking nowadays, which these patients usually they are like more resistant to the steroids. But again, the management will be the same for you in the emergency department. It should not be any difference. There are patients, for example, genetic-wise, they don't respond well to the steroids, and this is very common in Afro-American population. And also, you will have patients that they don't respond really well to the short-acting beta-agonist because of the receptor, the genetic composition between arginine and glycine will be vary. So depends of how they are dispositioned these amino acids, the patient will respond better or less to the short-acting beta-agonist. But at the end of the day, for you in the emergency department, it's not going to make any difference.
Okay. An asthma exacerbation arrives to the ED. What labs or imaging, what do you do?
So it is important to point out that for asthma, there's no many things or labs that you need to do. First of all, do pulmonary function tests on asthma exacerbation is not necessary. It's very difficult. You will need to have a good effort. So there's no point to do pulmonary function test. Chest X-ray in acute worsening, in acute status, it will be important. Now, this is the way that I will mention it or say it. If you have a patient that is first time coming in the emergency department, first time for him, new onset, I would recommend to do a chest X-ray to make sure that you're not missing something else, something new. Now you have a patient that is recurrent, always coming back with asthma all the time. You don't need to do a chest X-ray every time that they come to the emergency department. However, if you have a patient that is in the emergency department, even that you know already that is asthma, that it has acute worsening of clinical symptoms, the lack of response to asthma therapy, I would advise you to do a chest X-ray. And we will have some examples here for the chest X-ray. For example, you can have some hyperinflation in the chest X-ray. Here in this other imaging, we'll notice that we have a patient with a pneumomediastinum. It's very easy to see how if you follow all the direction of the heart borders, even the silhouette of the heart between the diaphragm and the heart, you should not see any separation. And here you see a very fine line between it and then around the heart. So that's a pneumomediastinum. So you know that these patients, you will consider twice before starting, for example, a positive pressure, because then it's going to get worse. What if a patient has a pneumothorax, things like that. In this other chest X-ray that I'm showing you here, you can see there's like a big atelectatic process, and then you will be worried. Maybe you need to do, in this case, if it's too sick, the patient, probably you have to add a positive pressure for this patient, non-invasive patient.
Okay, that's perfect. And CBC, CMP?
Yeah, so CBC really you don't need to do it. I usually do CBC, IG levels in outpatient settings.
Okay.
I will not do it when the patient is admitted, unless the patient has another thing. If the patient has fever, has some other condition, well, you may do a CBC. If the patient has any other comorbidity, maybe you need to do a CBC or any other pertinent lab. Now, in terms of metabolic panel, probably you can use it, especially if the patient will be admitted, to make sure to see how is the baseline potassium. We have to just remember that kids that are receiving continuous alveolar nebulization, they have increased risk to have transient hypokalemia, hypophosphatemia, or hypomagnesemia. So those patients, maybe you want to monitor.
So now you get these labs. Is there anything else, like a score or anything that we should know before starting our management?
Well, yes. When we talk about management, we have to understand that we have three pillars, and that's the way I will do it, right? Number one, to have a quick throughout assessment of the patient that we know that we're going to continue following. Number two, we will have an understanding that we have to address the bronchial constriction problem, the inflammatory problem, and probably the hypoxemia. And number three, we have to have an idea how we're going to discharge this patient, right? So when we're talking about the initial presentation of a patient, when he comes, we have to evaluate really quick as possible, right? And with the understanding that you have an ongoing follow-up of the clinical status of this patient. Now, there's different ways to do. The more that you have been working in the emergency department, you already have experience. It's very easy to do it, to assess a patient. But especially when you're starting in the emergency department, one of the best tools that you have is we have different diverse respiratory score systems. Now, I like to use the Pediatric Asthma Severity Score when we're talking about asthma because it's very easy to use. And the higher is the score, the worse is the severity of the patient. Now, it's very easy. You have to touch 5 points. Number one, respiratory rate. And I know, I mean, you are a pediatrician. You know, in this case, it's going to depend how old the patient is. And for example, if you have a kid that is 2 to 3 years of age and he has a respiratory rate of more than 40, you have 2 points already, right? Okay. And if you have the other point that you want to address is the oxygen requirement. But the oxygen requirement has to be noted when they are on room air. For example, if it's more than 95% on room air, that will be 0 points. If it's 89 to 92, will be 1 point. If less than 89, on room air, there will be 2 points. So again, the worse the hypoxemia is the higher the score, right? The other point, auscultation, how you hear the airway, if they have clear breath sounds, or if it's very diminished breath sounds, if you have inspiratory versus biphasic, inspiratory, expiratory wheezing, that will change your score system. The other point will be work of breathing. If the patient have accessory muscles used less than one, or if it's like more than three, this you know that the patient is very distressed. And the last point that you want to look in a pediatric severity score or respiratory score will be the difficulty to breathe or dyspnea, right? So if the patient is speaking full sentence, no problem, is tolerating the PO, we're fine. But if the patient start having like difficulty to talk short sentences, start having a grunting in case of a baby, very weak cry, he doesn't tolerate PO, you know that patient also is more sick. So in terms of the pediatric asthma severity score, mild will be if you have 7 or less, moderate if you have 8 to 11 points, and if you have 12 or above, that will be a severe score, and that patient most likely need to go to the intensive care.
Now that we know he has asthma, we did the labs, we have the asthma severity score. What would be your step approach for the treatment of asthma? And what is this about, the early and the late phase asthma?
Yeah, well, that's a very good question, actually, Armin. And we have to understand that a patient with asthma, when they will have an asthma exacerbation, we have something that we call early phase versus late phase. Early phase, it will happen really quick, and it's going to be triggered by any type of allergen, virus. Is going to trigger the airway. You will have the bronchoconstriction. Usually will peak around 30 minutes, and it's not going to last more than 4 hours. So usually if you're on top of that, you give the medication. In this case, short-acting beta-agonist, most of the time you will be able to stop the progression of this exacerbation. Why this is important? Because when the patient comes to emergency department, those patients most of the time, I would say 99% of the time, will not be in an early phase. They will be in a late phase. And a late phase is after 4 hours. At that point, you have a lot of influx of cytokines, a lot of inflammatory debris to the airway, so it gets worse. At that point, those patients, they will really require to start in a short-acting beta-agonist right away and a systemic steroids. So that's why it's important for you guys to understand it doesn't matter which patient comes to the emergency department. You need to have a mindset that the patient's already in a late phase, and it is important to do the systemic steroids.
The albuterol, I know like in peds, there's many doses that you need to scale for the weight. Could you kind of give us a ballpark of what we should know and what doses to use?
So there's many recommendations, depends what you read, but the National Asthma Education and Preventive Program, they established some guidelines and recommendation of dosings for pediatrics. I mean, again, it depends on the severity of the patient, but just like a ballpark, if you start we're not talking about continuous yet. If you're giving like treatment, you can start roughly between 0.50 milligrams per K per dose, and make sure that you don't go less than 2.5. At least it has to be 2.5 milligrams per dose, and with a maximum at the beginning of 5 milligrams, you can give every 20 to 30 minutes, and then from there, you can increase even to 0.30 milligrams per K. Make sure that you don't go above 10 milligrams per dose. Now, when you're talking about continuous, let's say that you have a severity score of 12, the patient is sick, probably is in bypass, and you need to start giving continuous by the time that they come to take a PQ, things like that. You can go all the way up to 0.5 milligrams per K. That will be with a maximum of 20 milligrams per hour. That's one way. Or the other one, it will be depending on the weight of the patient. If the patient weighs 10 or less, make sure that you don't give more than 2.5 milligrams per hour. If it is between 10 to 20 kilos, make sure that it is not more than like 11.25 or 12 milligrams per hour. And if it's more than 20 kilos, you make sure that you don't go more than 50 milligrams per hour. That's one of the things that I think probably you can use. Now, there's also recommendations how to use short-acting beta-agonists. Talking about inhalers, you can use 5 to 10 kilos. You can use at least 4 puffs. If it's 10 kilos to 20 kilos, you can do 6 puffs. And if it's more than 20 kilos, you can do at least 8 puffs. Now, the problem that we have is in order to use an inhaler, even with spacer, you need to control either your tidal breathing, or you need to have a good effort or maintain it. And so these patients at this point, they don't have a good effort. They're having difficulty to breathe. They are tachypnea. So using at that point and a spacer with a MDI is going to be a little bit cumbersome.
So you rather use the nebs in the ED?
That's correct. And the other point that they probably in favor to do the nebs in the emergency department is that usually you have to be connected to the oxygen flow, and usually has to be between 6 liters to 10 liters. So you're helping a little bit and probably improving the BQ mismatch.
Okay, and speaking of that BQ mismatch, whenever you give albuterol, you start the nebs, and the nurse comes in and says, "Doctor, the patient just started the nebs and he started desaturating." Could you touch on that a little bit?
Yeah, that's very common, and you see it. You can see it in the area. Sometimes even when you're admitted, really early in the morning, 6 a.m. in the morning, you will see that type of condition. What happens is you have a transient worsening of a BQ mismatch when you do albuterol. It's part of the physiology. And it is common. You have to assess the patient, make sure there's nothing else there, that the patient doesn't have it will have increased heart rate because you're giving albuterol, but it will not be like super high in the high end of heart rate. Make sure the patient is not gasping for air or it doesn't have any other clinical situation that is prompting you to do something else. Most of the time, it's just going to be a transient BQ mismatch due to the albuterol.
In transient, how much time?
Usually in 20 minutes, it will resolve.
Okay. And now that you touched on the heart rate, what heart rate, and of course, depending on the age, like everything in pediatric, but what heart rate should I be alarmed in order for me to maybe switch to a more specific short-acting beta agonist?
So let's say that you have a patient, a 3-year-old, 4-year-old, and again, this is very important. It's very difficult to say exactly what is the number, the magic number, because we're talking about kids and it's dependent on the age. But let's say you have a 3-year-old and you start with albuterol and then he's 120, 130, well, you expect 140, probably that's okay. But you start seeing 180, 120 right away after the dose that you're thinking about. This patient is very sensitive to albuterol, and you may consider to switch to level albuterol.
Okay.
And again, it sometimes happens that, as I mentioned, when we're talking about the difference of type of asthma, there's some patients that genetical-wise will not respond as well as other. There are patients that will respond super well, more than to albuterol again, and so maybe this is the case. So you can give level albuterol, and usually the dose for that will be one half of the recommended dose for albuterol.
Okay, so that's easy to remember.
Mm-hmm.
Okay, so we got albuterol on board. Ipotropium, could you speak to me a little bit about that? Is there a certain window that we need to give it in, or just speak a little bit about Ipotropium?
So the inhaled Ipotropium bromide is an anticholinergic, and then it's very well known nowadays. I think the best way to use it is in the emergency department. We have known that if we use quickly the Ipotropium bromide, we can decrease the admission rate for this patient, the chances to be admitted. But let me tell you, like sometimes and there's no data for this, but sometimes we will have very sick patients, we will, in the picture, sometimes we will use also the Ipotropium bromide. But the reality is that it is established to be used in the emergency department. You can use if the patient is less than 20 kilos. You will use 250 micrograms per dose. And if it's more than 20 kilos, you can use the 500 micrograms per dose.
Okay, you could mix it up, correct?
Yeah, well, that's the other thing. You have the combination of albuterol and Ipotropium.
Okay. Correct. How many doses could you give that one?
So you can, it's supposed to give like 3 doses for Ipotropium bromide, but again, if the patient is sick and you can go above that, but usually it's like 3 doses of Ipotropium bromide.
Okay, steroids. Could you speak to me a little bit about that?
So actually that's the other thing. So remember, we're talking right now like stepwise, but the reality is we try to do everything at the same time. Mm-hmm. We put in the oxygen if they need it, given the nebulization, and given the IV or PO steroids, right? So steroids is very important because we mentioned already these patients are already in a late phase. You need to stop the inflammatory process because otherwise they will be more difficult to break the exacerbation. And then you can use, depending how sick they are, you can do PO versus IV, in this case, methylprednisolone. The recommendations, those to use for prednisone and methylprednisolone will be 1 milligram per K, 1 to 2 milligrams per K per day. In prednisone, the max dose, depending what you read, can be between 60 to 80 milligrams. Methylprednisolone, actually, you can go all the way up to 125 milligrams per dose. Dexamethasone you can use, and you use the dose of 0.6 milligrams per K with a maximum dose of 60 milligrams per day. It can be, that one can be by mouth, IM, or IV.
Okay, that's good to know. Now, is there a preference between dexamethasone versus the others? Is there difference?
Yes, it is very controversial, but there's some literature mention that dexamethasone actually can work quite well, and then in terms of compliance, it will be easier to do. You have a patient that is going to go home, you may give the first dose of dexamethasone, the next day you can do the second dose of dexamethasone, and you're done with it. If you think that the patient will require prolonged use of steroids, because probably it's the third admission in the month, he doesn't need to be admitted, but you want to send him home, probably you will really need to give at least 5 to 10 days steroid course, and probably if it's more than 5, I will do prednisone. And if the patient is going to be admitted or it's in BiPAP, probably you will need IV, probably methylprednisolone will be the best choice in that case. So it depends on the clinical scenario of the patient.
That's interesting. So now 10 days. Is there a need for weaning, or do you just cut it off?
That's very, very good question. There's no right or rhythm how to do a weaning, but usually patients that they have, they use steroid course no more than 10 days, probably they will not require to use taper. But if you want to do taper, especially if my patients use the steroids more than 10 days, I will do taper it. Again, there's no way to do a tapering correctly, but usually what I recommend is to do decrease after you finish, let's say, the 10 days that I know that I take this patient. You will take it for at least 10, 12 days, whatever. And then after that, what I will start doing is decreasing the dose by 50% every 2 to 3 days. And that way you will diminish and do a proper taper with time.
Okay. And what's the role of magnesium in the asthmatic patient?
So, again, magnesium is one of these drugs that sometimes is controversial, that they say that it should be used only by PQ and things like that, which is not the sense. We know that the magnesium sulfate can help a lot. Patients that there's very difficult, they're on distress with high severity score, I will add magnesium sulfate to these patients, just with the caveat that these patients, they can have hypotension, so make sure that you have well hydrated these patients, and then you can use it as standard doses like 50 milligrams per K or 0.2 millimoles per K via IV, and then make sure that it doesn't pass more than 20 minutes. One of the things that if you see that the patient, you start him on magnesium sulfate, there's no good response of it. There's some studies showing that there's some genetic variability of some patients that will not respond well to magnesium sulfate. Is that the case? Probably those patients will not be a good candidate to do a drip.
Okay. And so speaking of the hypotension and the magnesium, if you're using magnesium, more than likely you're going to be admitting the patient, correct?
Well, yeah, it can happen, but it depends on the institution. Their institution, they allow the patient, if they get there, to send home of magnesium sulfate. That will depend on the comfort of the attending. But yes, most of the time, I agree with you, they have to be admitted.
Okay, and is there a role for a bolus in the treatment of asthmatic patients?
So actually, yeah, the cardiac output is a little bit diminished. Remember, we have a lot of hyperinflation, so the way that the heart is pumping is a little bit more difficult for it because of the hyperinflation. So it's important to make sure that the patient is well hydrated, not to overhydrate, right? No more than one maintenance probably, but there's a role to give at least one bolus for these patients with asthma exacerbation. Yes.
Okay, perfect. So now you have this pretty sick patient. We already spoke about the medical management, the drugs that you would use, but you have this sick asthmatic patient. In terms of respiratory support, what's your preference? What's your go-to, and how do you escalate from that?
Well, talking about the hypoxemia in respiratory support, it will depend on the clinical condition of the patient. If the patient basically is is stable, but probably, let's say, has O2 saturations in the, I don't know, 87, 89, probably nasal cannula, he's not breathing too fast, probably that would be the way to go. But if a patient has a high asthma severity score, my way to go is to do a non-invasive positive pressure ventilation.
Okay. Any recommendations on the settings that you would use?
Well, you start with a minimal doses. We have to remember, and I think probably it was too short in my answer, but when patients have a severe exacerbation of asthma, they have a lot of influx of inflammation, which I already mentioned. A lot of the bronchospasm is severe. You have a lot of mucus production. And then, therefore, what is going to happen, you will have an airflow obstruction in the distal airways. This is going to increase, and this is very important to understand, is going to increase the airway resistance and develop long expiratory time in the lungs unit. This is important because when you have that prolonged expiratory time, what is going to happen is you will start trapping air, a lot of air trapping, and then you will have a dynamic hyperinflation. When you have these two entities together, you will have the infamous auto PEEP.
Okay.
And why this is important to understand, because when you have this auto PEEP, you will have an increased work of breathing, and you will require a negative force to be increased just to be able to grab air and then put it into the lungs. And so imagine these kids, small babies or 2-year or 5-year, to having this effort all the time, being tachypneic with very short time to exhale, they will crash right away.
Okay.
So when you do a non-invasive positive ventilation in this patient, in this case CPAP or BiPAP, what is going to happen is that you will have stent open that narrow airway, or that airway that maybe is already collapsing. Therefore, you will have a better complete exhalation. This patient will have better time of expiration. And in the other thing that is going to help you, because you will have a certain amount of PEEP given for this patient. If just really quick to go to physiology really quickly, when in an adult, for example, when you have tidal breathing, right, at FRC, right, a normal breathing, what is going to happen is that gas exchange area in the lung is going to be around 3.5 liters.
Okay. When
you take a deep breath, that is going to increase, that respiratory area, right, is going to increase almost to 5.2 liters. So you're increasing your area of oxygenation. So with this patient, when you increase that PEEP, also you give more area of diffusion, and that will be explained by the fistula. And those patients also, you're improving exhalation time, and you're improving also their oxygenation. So that's why it's very important to try to use non-invasive mechanical ventilation. The question that you're telling me how much and which one I will use, well, it will depend. Like if I have a patient probably that is not too sick, talking about, let's say, if it requires an FiO2 between 0.25 to 0.70 of FiO2, or maybe the gas, the CO2, is not more than 50, probably you can go with CPAP. You can start at 5 or 6 centimeters of water, and then you can start titrating until you achieve the goal that you want to have, probably to make sure that you have oxygen saturation above 90%. And I will jump, my particular point of view is I jump right away to BiPAP, to be honest, but other way to do it, if you want to have when to use this one or other one, the other one is you have a patient that you have a hypercardia above 50 millimeters of mercury, or if you have a FiO2 requirement above 70, then I will go to BiPAP. And what you want to do is you set up an inspiratory pressure of 8 to 10, and then you go and you can again titrate up. And the EPAP or expiratory pressure will start around 5 also.
Okay, that's good. Now, Vapotherm, do you use it? Is there room for it?
There's definitely room of it. You can start with Vapotherm. That's okay. You make sure that you do 1 to 2 liters per K, and depending of how much it weighs the kid, make sure that you don't go past the maximum liters that they can handle and there's a table for that. Definitely you can use it, but again, I think for me, this is just my preference. If the patient is really sick, I prefer to use go to BiPAP right away and try to avoid intubation.
Everything goes south. Your respiratory support is not meeting what you thought was going to help out this patient. When do you think about intubation in asthma?
I try not to think in intubation about asthma, to be quite honest. You really try to avoid intubation. It's very difficult to extubate the patients. Just think about the process of asthma. The biggest problem of asthma is that you don't have enough time to exhale, right? That's a big issue. When you have a tube, it will, number one, and I probably will explain again, similar what I explained with a BiPAP, you have increased resistance. You have auto PIP. When you're putting a tube in an tube, you increase your resistance also, okay, right? That's a worsening already. And then you have it on a circuit. So what is going to happen is you're going to start increasing more air trapping. And it's very difficult to extubate these patients, very, very difficult. Sometimes when you intubate those patients with asthma, they are so sick that either they may need to have also anesthetics gases to improve the airway obstruction in order to help them later to be extubated. It's a complicated situation. Probably I have seen couple, and since I did all my fellowship, one in Texas Tech, they're required to have been escalated to be intubated and to use some anesthetic. But usually we try to avoid intubation. And that's one of the reasons that I was mentioned earlier when you asking me, do I do high flow versus non-invasive positive pressure? I will prefer to do right away non-invasive because that way probably I can control faster the patient that I will do high flow, is going to get better or not, and then I need to escalate. I think I gain time to start earlier CPAP or BiPAP.
Okay. And that's very interesting that you told me about the anesthetic gases. So hopefully not, because like you said, avoid intubation at all costs. But if you're going that way, if you think you're going to intubate, then you more from the ED, you're kind of calling the anesthesia team already to start getting.
That's correct. You have to talk your PQ, you have to talk anesthesia, because we're talking about something that you never want to see. This is you're giving me a scenario that you don't want to be on it, and you don't want the patient to be on that. It can be as sick the patient that maybe he needs to be transferred to be placed an ECMO until he recovers for the airway obstruction. So it's a really, really, really gray situation.
Patient is really not responding as well to the treatment. Is there room for Heliox? When do you use it?
Actually, that's a very good question, Arvin. So Heliox, you can use it even before BiPAP or during BiPAP after that. The only caveat with Heliox, we remember Heliox is the combination of oxygen and helium, right? So what happened with Heliox is, if you guys remember, the air flow, we can have something that we call turbulence, and that will be give you by the Reynolds number. I'll probably being too deep into that, but the way to understand is that if I have a very big radius of airway, if I have a very high velocity, if I have a high density, there's going to be a turbulence. Okay. And especially if my viscosity is very low, you're going to have a turbulence. Now, in this case, the problem is not the radius, it's the velocity, because the way you're trying to breathe in and breathe out, and also the mixture of air is going to be very dense, so you're going to have a lot of turbulence. When you use Heliox, actually, the density of the gas that you're breathing in and breathing out, and the viscosity increase. So you increase the viscosity, you decrease your Reynolds numbers, meaning you will have a better laminar flow instead of turbulent flow. So that patient will trap less air. Now, the problem with this is that you cannot have a good oxygenation with this patient. And again, that's why I think BiPAP is better. Because in this case, this patient, what is going to happen is the combination is like a concentration of 20% of oxygen, and helium is like 80%.
It's like room air?
It's almost like room air, basically like room air. And so basically, to oxygenate a patient on Heliox is not as easy as we think. So again, I think the best way to go is, if it's a severe patient, it's a non-invasive positive pressure ventilation.
Patient, we didn't send him to PICU. He's going home, but we want to evaluate his response. Do we use a peak flow to monitor the response?
Okay, so there's a lot of data that you can use the peak flow. There's a lot of places that they use peak flow. I personally, and the way that I was trained and all the concepts that I have with some pulmonologists, that we don't like to use the peak flow in an emergency setting. And the reason why is because we have to understand that the peak flow is going to be effort dependent.
Okay.
This is very important. And basically what we're trying to do with the peak flow is to mimic what will be FEV1, forced expiratory capacity in the per second. But the reality is going to depend on the effort. Now the effort, if you're if you know, especially adolescents, that they know that if they have these certain numbers, they can go home, and they may fake it. And even if they feel very bad, they can do a good job. And I will demonstrate this in this case.
Okay.
So imagine, I don't know if is going to be able to see, I will put my hand here in my chest, and I'm going to breathe to see if I can blow out this paper, okay? Like this, right? So I'm going to put my chest and see if you can see my chest moving.
Okay.
Right?
Yes.
Probably you can see that. Okay.
No, I can see it. Mm-hmm.
Okay, so we will try, right? This is up, and tell me if I can move the nap.
Moved. Moving, right. But the chest.
The chest is not moving. Now I'm going to do the other way. So in this case, my chest is moving, and I'm barely moving my napkin, right?
Mm-hmm.
Now this is everything is normal. The point that I want to make is it's going to be effort dependent. So if I have the ability and I know what I'm doing, and usually peak flow is going to be done by adolescents, you will not give a peak flow a 5-6-year-old because they don't know how to use it. They can force it. They can just grab all there from the upper airway and giving you a good effort. Now, if you have an upper airway obstruction, you're not going to be able to generate that. But again, that's why we don't like to go by peak flows. I think it's better to go by symptoms. And again, that's why you can use your respiratory score system.
Okay, and that being said, would you use that respiratory score system or any red flags that would guide your disposition?
Yes, I think the respiratory score systems, whatever you want to use is fine, because you can see how the patient come in and how he's doing right now. He's getting worse, getting better, and it can give you a sense, more objective sense of how the patient gets better. And then again, at the end of the day, if compared with a peak flow, although you can use it and it is okay, it is recommended, that's my caveat, that it's effort dependent. You can use only, probably talking about children, you can use in some certain kids. Not all the kids can do peak flow, so that's a problem already with that. But if you do the respiratory score system, whatever you want to use, you can use through all ages.
Okay. Kind of for the respiratory score that we're using, is there a number that would kind of guide us to PICU, another one to wards or home?
Well, yes. Again, it depends on what score system are you using. If you're thinking about the pediatric asthma respiratory score system, that one, if you have a mild exacerbation, will be less than 7. If you have from 8 to 11, will be a moderate, and more than that, 12 and above will be severe. Those patients, moderate or severe, they have to be admitted. But in mild, will depend. Why? If you have a patient that it comes with a respiratory score of 6, and you're doing all the treatment, but continue to be in 6, the patient is not ready to go home. It's doing the same thing. So probably you have to admit it. So again, the clinical presentation of the patient is really improving. Say he came with a score of 9, now it's a score of 6. Came a score of 7, now it's a score of 5, 4. Then probably you can start thinking about this position.
Okay, I like that scoring system. Now, he didn't meet our criteria to admit. We're going to send this patient home. What do we discharge him on, and what are kind of like the ballpark doses, and is there a need for extensive education as the emergency department physicians?
So this is very important. So number one, you have to make sure that you establish a follow-up for these patients, okay? Make sure that they're going to follow up the pediatrician, probably 1 and 2 days after seeing you guys, and probably they can be sent by pediatric pulmonologist or asthma specialist. You can send them. One of the other things is that if the patient is already not on controlled medications and you did the diagnosis of asthma, it is okay to start a medication. You can make that decision. You can go to low or medium dose of the patient that you think is that he required to be on controlled medication, and that way you are ahead. We have to understand that when we have patients with asthma exacerbation, usually we give like 5 days of steroids.
Okay.
So by the second week after the exacerbation, they will not have any more effect of steroids. So if you discharge these patients on an inhaled steroids while they're already on systemic steroids, it's a safe situation. Why? It's very safe because the inhaled steroids, when it's new, first time, it takes 2 weeks to start working. By the time the systemic steroids are not anymore in the system, now the inhaled steroids start working. And at that time, probably the patient already is with a PCP or with a pediatric pulmonologist, and they may reclassify, make a change and adjustment, or keep it the way you started, but the patient will be ahead. Now, the other point that I remember is a lot of people, when they start a systemic steroid, let's say it's a patient that you know is asthmatic. They come, he's going home, you give steroids, and sometimes, stop your inhaler because I'm giving steroids. We don't do that. Okay. It is safe and it is okay to continue with the systemic steroids and the inhaler, okay? Because otherwise, what is going to happen, the inhaled steroids that you're giving, if you stop it, they're going to stop working in the lungs, then you will start it until you're off of the steroids. So we'll have like 1 week without any protection in the lung. And remember, when you have an exacerbation, you have an increased risk of exacerbation of another exacerbation in the future. So you want to diminish that risk.
So whenever you're going to send them on the inhaled corticosteroids or the controller, you send them on the systemic steroids, and you're going to send them home with the albuterol. Is there any specific way that you instruct the parent to give it every so often?
There's no right or wrong how to use follow up the dosage and frequency of albuterol. The way that I recommend to do and how I talk to my patients when I give that is I usually recommend, and first of all, with the understanding that all this recommendation is going to depend if the patient is getting better or not.
Okay.
Like if the patient is getting sicker, he needs to know that he needs to go back with the PCP or go back to emergency department, or I don't know if it's too severe to call 911. So you have to explain all the alarm signs, right? Okay. But let's say the patient is fine, doing well. What I like to recommend is to use albuterol every 4 hours, either via nebulizer or MDI, every 4 hours for 48 hours for 2 days. And then later, if he's getting better, then the next day I will do every 6 hours for 24 hours. If he's get better, then the next day every 8 hours, right? And if he gets better, the next day every 12 hours. But when when we reach every 12 hours, what I recommend to the patient is to continue every 12 hours until they don't hear cough for at least 24 hours.
Okay.
So they may be 3-4 days of every 12, or until they see the pediatrician or their specialist and they say you can stop it or not or whatever. The other point that we have to explain to the parents, because we're giving the control medication usually is every 12 hours, right? Mm-hmm. And when we're giving the albuterol, it can be every 4, every 6, every 8, every 12. But at some point, it's going to time at the same moment that you have to give the control medication. We have to explain to the patients that we need to use first the albuterol, in this case, the Prayer, the Ventolin, whatever brand do we have, because that way you're going to have a bronchodilator first. Okay. So you will have a bronchodilation, then after that go your control medication, and that way the medication go farther into the airway.
Okay, and speaking of the medication going farther into the airway, using the albuterol, use a spacer, do you not use a spacer, why or why not?
Okay, so yes, Armin, you know me already about this, but you know the answer. But it is important, of course, if you have a kid less than 3 years of age or so, They will need to be on nebulizer. We know that. Make sure that when you send them home, they have the actual nebulizer. If not, you have to contact social services. Make sure that we can make sure that they have the device before they go home. But talking about inhalers, it is important that no patient should use an inhaler without a spacer, unless something happened and you don't have a spacer around. Why? Because of the position of into the lungs without a spacer is very, very minimal. Okay. We have to understand this part. An inhaler, usually an inhaler, will have very, very small amount of medication, like 80 to 90% of the medication is going to be propellant. Okay. The rest is going to be very minimal. 4% to 10% is going to be medication. Now, it's important to explain to the patient they have to shake for that reason the inhaler. And then if you don't do that, if you just take in directly into the mouth, around 70 to 80% of the medication when you use directly into your mouth is going to be in your oral cavity. Okay. Less than 10% is going to reach the lungs. In top of that, you didn't shake it. So probably less of medication is going to get to it. Now, what they discovered is that when you have the metered dose inhaler or the HFA, when you add the spacer, but the spacer has to have two qualities. One, it has to have a valve holding chamber, right? Mm-hmm. With a non-electrostatic properties. What does it mean, right? Well, you have the spacer, which has a valve. You give a puff, so the medication doesn't go anywhere. It's there. So the patient has time, if you're using with mask, it has time to take that tidal breathings at least 10 times, or if it's a patient that it doesn't require any more the mask, it has the time to take a slow and deep breath and hold them for 10 seconds, right? Okay. The other part, that the non-electrostatic part, is very cool, because what happens is that the charge that the molecules of the medication of the powder has are the same that are in the spacer. Mm-hmm. So it repels. So it's not going to stick the medication in the spacer. So again, you will have better deposition. When you do that, when you do a proper technique with a spacer, that it has a holding valve and also has a non-electrostatic properties, what is going to happen is going to increase from less than 10% to 40% of medication going into it. So it is very important to educate our patients, and you have hear me saying this all the time over and over to my medical students, my residents. The cornerstone of treatment of asthma is education. If we don't have the ability to educate our patients, it doesn't matter what are you giving, they will not improve. So they need to know when to use it, how to use it, and they have to know the difference between a controlled medication versus a rescue medication. There's many times that you have seen in the emergency department that they tell you, I'm using the Flovent every 4 hours, or the Cuba, or any type of brand, but it's not getting better. Of course, it's not getting better because that's not a medication of Flovent, that's a controlled medication, okay. Right? So it is very important to make sure that before they go home, to have a quick system. You're an emergency, it has to be chop, chop, chop. A system where you make sure that the patient know what they're doing, or the parents in this case, and that they have the proper medication, and they have either the spacer or the nebulizer to go home with a proper follow-up.
And I think that's very important that you mention it, because like you very well said, you want to do things fast in the ED, but if you do it too fast, then you're going to skimp on the education. And if you skimp on that education, more than likely, if he doesn't use a spacer or uses the controller instead of the rescue medication, then he's going to come back and you're going to say, why is he back? Maybe he didn't respond well to the treatment I gave him, but it's actually just in the education and the time that you spent with the patient in a fast way, like you said, but hitting all those points, that's going to improve the outcome of the patient. So I think that education, like you mentioned, is the cornerstone of the treatment, and thanks for expanding on that.
That point is very important. Probably one of the best ways to do this is when you go with the patient that is going to go home, just really quick, make sure that he knows. That not only say it, I think the best way to do it faster is, can you tell me how are you going to use this one? And they will tell you, Papa. If they have a mistake, did you correct it? They will learn it faster. if you just say do this, sometimes they don't even put in attention. But when you put them on the spotlight, suddenly they're putting attention and they're getting all the information. I think that's one of the best way to do it.
Okay. And last, when they're discharged, is there a need for them to see their PCP versus the pulmonologist? When do you do one or the other?
So they always have to see the PCP. This is very important. The primary care physician, they know them very well. They know if they have any other comorbidities. So we never going to replace the PCP. They always need to see the PCP. That's the main character in the healthcare for that patient. So make sure that they follow with the PCP. Now, if we think that we have a moderate persistent or severe persistent, probably would not be a bad idea to send to the pediatric pulmonologist to help them to tailor the care for the patient with asthma.
Okay, perfect. Well, I think that is a wrap up for asthma. And now to change it up a little bit, I have this patient that kind of looks like asthma, but he is 2.5 years of age, maybe a little less. He has a bunch of snot coming out of his nose, maybe not eating well. What do you think this diagnosis could be?
So, first of all, I will tell you at that point, if it's what you say at 2.5 years of age, I will tell you is this just a viral infection or is asthma exacerbation, whatever it is. What is important to point out that it is not bronchiolitis. By definition, bronchiolitis is a kid that is going to be less than 2 years of age with the next features. It will have some upper respiratory feature, like you're like a little bit congested, runny nose, probably cough, plus low airway respiratory symptoms, especially like wheezing, right? And again, this is very important to understand because when we're talking about bronchiolitis, we know that the treatment, all the therapy that you use for bronchiolitis is supportive care, versus if it's more than that, maybe something else, maybe it's a pneumonia, maybe it's an asthma exacerbation, and now you have to deal with different treatment management. It's very important to understand bronchiolitis, less than 2 years of age, supportive management.
What supportive management?
So again, you have to assess your patient. You have to have a certain respiratory score system, right? You have to check respiratory rate. You have to check if they have using a lot of respiratory muscles. We have to remember, especially these kiddos are less than 2 years of age. So these babies, they will have increased compliance comparing to the adult or the adolescents.
Okay.
So for them, you will see that paradoxical abdominal breathing, a lot of retractions, suprasternal intercostal retraction, nasal flaring, because they need to improve their negative pressure in order to get air into the lungs. So that's the way to assess those patients. And you will see if they're hypoxemic or not. So what you need to, and then the other important part of these patients is they're eating, if they're dehydrated or not. So basically what you want to do with this patient is make sure that they're feeding or not. If they're not feeding, you may need to do an IV access and replenish the fluid, maybe bolus, then maintenance. If the patient is hypoxemic, probably you need to address what type of respiratory support these kids will have. But that's the real treatment. If they have fever, management for the fever, but that's what you do for patients with bronchiolitis.
Okay, and I've noticed you're saying hypoxemic, and you've grilled me on this, and that stayed with me forever. Hypoxemic, hypoxic, are they synonyms? Are they not? What is wrong with using one versus the other?
So I think that it is important just to point it out, especially when you're learning and you're like in this pathway to learn and to do better notes. Hypoxemia basically is how much of oxygen you have in the bloodstream, period. That's what it is, either by saturation of oxygen or partial pressure of oxygen. When we're talking about hypoxia, we're implying already there's a tissue damage, okay? So one example, when you have like infarcts or brain infarcts, or when you have ischemia or any type of situation like that, that's when you're talking about hypoxia. So if I wording in a patient came a 3-year-old who come with hypoxia, this and that, and later you have a case, a lawsuit, and why you didn't do this, and this, the patient will already have hypoxia. although it's not true, it's hypoxemia, right?
Mhm.
So it's important just to understand that there's a big difference in between when you type, when you do working of all those. So I think it's hypoxemia. We're seeing hypoxemia.
So I've seen short-acting beta agonists used for bronchiolitis. Why is this, and why should I not judge whoever did it before asking questions?
This is very important. It's very common to happen. Sometimes we have this sense of things that we do with certain conditions. And we have to understand that in the past, we used to actually use albuterol for treatment of bronchiolitis. We know now that it is not recommended. Why? Because it doesn't improve the outcome. It doesn't decrease the length of stay of hospitalization and the days of sickness. So albuterol doesn't improve the bronchiolitis. It is a room to use albuterol? Well, it depends. If you have a case that is a first time being bronchiolitis and nothing else, never used albuterol in the past, nothing else, you don't use albuterol, you don't need to use it, this is bronchiolitis. You address the hypoxemic process, if they are dehydrated or not, and then the temperature if they have or not. However, this is the patient that it comes, is the third, fourth time that it comes in a year. That at home, they always use albuterol because you give albuterol, they will have a cold that lasts for 2-3 weeks. The name of the dog is Asthma, and when instead of barking, he wheezes, and the last name of the mom is Floven, and asthma platelet index is positive. Those cases, you may do a trial of albuterol. Now, if it is improving, now you know this is not bronchiolitis. Why? Because bronchiolitis doesn't improve with albuterol. This is an asthma exacerbation, and you have to treat it as such, as an asthma exacerbation, and then probably you need to start the steroids because we're not dealing anymore with bronchiolitis.
Okay. So now, a patient that's coming in and he's day of illness 3 in this bronchiolitis case. What should I look out for, and what is kind of like the flow of the disease, and why is the days important?
Well, this is very important because we know, and you're a pediatrician, and as a pediatrician, it's green on us that the bronchiolitis is going to get worse before it get better, right? And usually it depends on the viral. We know that most of the viral, like RSV, probably rhinovirus, you will have a peak of worsening of symptoms around 5 days of illness. So you have to have that in consideration. But if you have a patient that comes at day 3, but is feeding well, he's not hypoxemic, he doesn't have fever, he doesn't have use of accessory muscles, well, you can send still home. But if the patients had a fever, you cannot break out the fevers. Maybe you suspected a superimposed infection there. Probably the patient is not tolerating EO, you have to give IV. He's hypoxemic. Again, those patients you will not send them home, you have to admit. So it's based on the clinical condition.
Workup in the patient that looks like bronchiolitis. You get biofires. Do you just clinically diagnose why or why not? And would you consider doing an ABG in the respiratory patient in general?
So the recommendation that exists right now for the American Academy of Pediatrics, you don't need to really use the PAID panel. If you think it is a bronchiolitis, you don't need to. You want to make sure that you maintain the oxygen saturation about 90%. That's the recommendation. And basically, that's what you need to address. If you have a patient that it has a severe respiratory score, I will do not only bronchiolitis, probably asthma, and any type of respiratory condition. I will do definitely an ABG. If you cannot do ABG, then I will do a CBG. That's a little bit more accurate than a BBG. Physiology, right? If you think about the artery having the best gas picture, right? Then the capillary is going to mimic a little bit more the artery, and then the venous, I will be shy away a little bit more of the real picture of your artery content, which that's actually what you want to look for, the artery content.
Okay, good. So I know you touched up a little bit, but just discharge criteria, disposition. What do you say? He stays or he goes for the bronchiolitis?
Again, I think respiratory score system will help you a lot if the patient is continue to have an increased work of breathing, requiring oxygen, is dehydrated, high respiratory severity score, I will admit that.
Dr. Dominguez, before we wrap it up, could you briefly touch up on the differential diagnosis of bronchiolitis, which is pneumonia? When would you start thinking one versus the other?
So I think when you have in terms of bronchiolitis, and I will divide it into bronchiolitis on an asthmatic patient. In terms of bronchiolitis, I will think about a patient who has persistent fevers like probably come day 6, day 7, when you know the fever should be getting down, right? Probably at that point, then you will do the chest X-ray and to see if you find any consolidation, right? And then you have to treat it. In terms of asthma, again, if you have a patient who, beside the typical asthma symptoms, the wheezing, shortness of breath, cough, the patient start having fevers, and then probably it's between 5 years of age, 7, 8 years of age, and usually he doesn't get this type of exacerbation. Is then when I will start thinking about pneumonia, and especially in this age, I will start thinking about mycoplasma pneumonia, and then I will do probably chest X-ray. But at the end, you have to cover for both, right? You have to give your the choice is ampicillin, or if it goes home, amoxicillin with azithromycin.
And typical X-ray pattern that you would look for in the
So
patients?
viral pneumonia usually is going to be bilateral most of the time. Round pneumonia is going to be more common in bacterial pneumonias, and the reason why we have these bacterial pneumonias, especially in kids less than 5 years of age, is because the pores of Kohn and channels of Lambert are not well developed. So basically, if you have an infection in the certain point of your lung, because you don't have those channels or those pores, they're not connecting well enough, you will have all the infection in that area localized, and that's why you see these beautiful, imaging-wise, beautiful round pneumonias, right?
Perfect. That's really good. Well, Dr. Dominguez, thank you very much for this talk. I learned a bunch. It's been a pleasure having you here, and hopefully this is not the last time you come and chat with us here in the emergency department.
No, thank you, Erwin, for inviting me, and especially thank you to the emergency department from Texas Tech to give me the opportunity to be sitting here and talk with you guys. And I'm around. I'm in the campus, so if you guys have any question, whatever, I'm available.
We will definitely give you a lot of questions, and hopefully you could come out and join us another time.
Thank you. Bye-bye.